So here we are, ESVS Day 2. I've been joined by Professor Alison Halliday, who's going to talk to us about the ASCT2 trial. Professor Halliday, lovely to have you. Would you like to introduce yourself to our audience?
Thank you. And so I'm Alison Halliday. I'm Professor of Vascular Surgery in Oxford University. And the ASCT2 trial stands for Asymptomatic Carotid Surgery Trial. And it's a follow-on from our original ASCT1 trial where we compared operation with medical treatment alone. And that finished some years ago. And what we found then was that it was pretty clearly better to operate in the long term than it was to just use medical treatment alone if you had tight carotid stenosis and were otherwise fit for operation and follow-up for at least 5 years. The difference then in the ASCT2 trial is that we're comparing two procedures, and when you're comparing two procedures, there's not necessarily going to be such a big difference. So in our first trial, we had 3,120 patients. There was a clear difference in favor of surgery. This trial, we plan to have 3,600 patients, and we're already at 3,400, slightly over that.
Okay, so that's very good recruitment. So when do you think this is going to finish recruiting based on your current trajectory?
So we should be finished recruiting probably in about 6 months' time.
Okay, which is really good news
Yes.
for those of us who've been waiting for these results. And at the end of that, what is the main outcome measure you're looking for in ASCT2 that we should expect to hear about?
Well, both procedures are stroke prevention procedures. So what we really want to look at, obviously, is the stroke rates between both of them. And we also want to look at not just short term, but actually really long term. So although we will get 5-year results within the next year to 2 years, we will actually need to have 10-year results to look at the not just the original efficacy of both procedures, but in fact the durability of the procedures in terms of how well they prevent stroke.
Okay, and are you concerned in either group about looking at long-term impacts of white matter change and the potential for dementia that has been raised? Of course, Ross Naylor's recent review suggests that there isn't a detectable change in that, but do you think, what is your impression from these patients?
So I think the way that people measure it, people are measuring short-term changes like cognitive function changes, seems rather difficult from that and from the white matter changes to be sure that they translate long-term into any real differences. And the current CREST-2 trial that's going on, which is going to involve about 2,500 patients, wants to select 500 of those who have impaired cerebrovascular reserve and look at those on medical treatment, those having stenting and those having surgery, have MRI sort of done before and after and follow them for up to 4 years. That really will only provide short-term cognitive function information. So I agree with Ross, it's difficult to really see if there's something in the long term that will be telling us that.
And do you think over the time that you've been running these trials, of course we've had a lot of changes in medical management that have impacted on carotid surgery quite greatly. How has that impacted on you and running the trial and recruiting patients when probably the number of carotids done has gone down over the last several years?
Well, it certainly has in Britain, but it's probably not true everywhere else because, of course, the population in Britain as well is getting older. And I was going to say, I'm glad you've asked that question because specifically in the UK, some years ago, they used to ask for carotid ultrasound as part of the measures of whether or not stroke care had been carried out correctly, and they have dropped that request some years ago. So it is no longer a stroke unit imperative. I mean, it's a clinical decision that they have to do, but it's curious that no longer is that part of it. And of course, with the onset of 7-day TIA clinics, people are not coming into hospital for so long. Yeah. So I don't actually know, since we still have 100,000 strokes a year in the UK, I don't know why the numbers are going down, but I wouldn't be at all surprised if people are being missed. So as for other countries,
for reasons that hopefully this trial will impact on, we should see that potentially being looked at again.
Well, I think we do have to look at registries from all the VascuNet registries, and that's expanding amongst other countries as well. And only yesterday I gathered that Serbia is about to start their registry and so on. So as Marit Venermo, she's the new Secretary General coming up for ESVS, and she has as one of her main aims over the next 5 years that we should actually have proper registries throughout Europe. And that, I think, will make a big difference in looking at the prevalence of stroke and how well it's being treated and what proportion of them are actually having carotid interventions, what difference that's making. Specifically about medical treatment, so I think the medical treatment that's made the biggest impact, because a lot of people are on antiplatelet agents, but the biggest impact is definitely coming from statins. Undoubtedly, you can reduce the risk of stroke and the risk of carotid intervention by about a third or so if you're on a statin before you actually have a symptom, or on a statin before surgery. Yeah. So I think that's true. However, you may still have a similar benefit afterwards because you've reduced the risk.
Okay, so some complexity to unpack. Well, thank you very much for joining us. It was a pleasure as always.
Thank you.
Enjoy the rest of the conference.